So today we will be covering barium enema, also known as the lower GI. We did the upper GI the last couple of weeks, so this is the lower GI. Now, the upper GI included the proximal portion of the small bowel. And now the lower GI, the upper GI was the small bowel, then we did the small bowel, which was from the jejunum to the ileum. Now we're going to cover the rest of the lower GI, which is the colon and the other accessory organs, okay? So a barium enema is a study of the form of the large intestine. The purpose of the barium enema, or BE, is the radiographic examination of the large intestine. Now, I'm going to get into the nuances of the terminology here in a bit because there is a difference between when you say colon and large intestine. Okay? Oftentimes you have technologists using those terms interchangeably, but they actually mean two different things because one or the other will be inclusive of other parts while the other is exclusive of other parts. Make sense? I know.
It will.
It will in a bit here. Okay. Most barium enemas are done as a double contrast study using both barium and air. All right, so here, let's go get to the nuances. Okay, so here we have, it says here large intestine anatomy. So here's the difference between colon and large intestine. Colon just simply means the four main segments. You've got the ascending colon, the transverse colon, descending colon, and the sigmoid colon. That's your colon. It also includes your right flexure, which is the hepatic flexure, and then you have the left flexure, which is the splenic flexure. Okay, so colon is ascending, transverse, descending, sigmoid, and then the two flexures. Okay, now large intestine includes all those, but we're also going to include the cecum, the rectum, and then the canal. Okay, so it includes those three other parts: cecum, rectum, and the canal.
Those three parts are what?
They're included in the large intestine. They're not part of the colon, they're part of the large intestine. Okay? So when you say large intestine, that's everything. When you say colon, that's just parts of it. Okay? All right. All right, so here we have a lateral view of the rectum. The rectum and the anal canal is part of the large bowel, not the colon. An understanding in the anatomy of the rectum is crucial when performing a barium enema. Are you guys all familiar with the barium enema? Yes? Okay, so it's just that. What we are doing here is we are inserting a rectal tube, okay, to the distal part, and proper insertion is indicative to avoid any type of injury. Okay, because when we're looking at the anatomy here, you can see that the opening is this way, and if you keep going in this direction, you're going to perforate the bowel. Okay, so there is a technique to that. We'll cover that later on. But if you have to go slightly a couple of centimeters this way, and then you have to angle it going towards the back. If you keep on going, you're going to pierce and perforate something.
Hanger right.
Yeah. Okay. All right. So the rectum is approximately 4.5 inches long. I was reviewing the slides. I think it said 4.4 or 4.7.
4.4.
Okay, it's changed it to 4.5. So it's 4.5 inches in length, and it starts at the third segment of the sacrum. Bless you. And it does conform to the shape of the sacrum. So it has that curve. The rectum makes a couple of turns. So it goes from the sigmoid, it goes down and towards the back, okay? goes down towards the back, and then it goes anteriorly, okay? And at the most distal part, it makes another turn towards the back. So it goes back, front, and then back again.
It's almost like the stomach.
Kind of like the stomach, okay. Yeah. The anal canal is approximately 1 to 1.5 inches in length. And again, we'll discuss this anatomy in greater detail when we talk about the insertion of the enema tip. All right, so here we have a radiographic image of the large intestine. Again, large intestine is inclusive of all the parts. Just by looking at this, is this a single contrast study or a double contrast study? Single contrast study, okay? Again, most barium enemas are done as a double contrast study because a double contrast, when you have air introduced in there, you can see the mucosal lining a lot better, just like in the stomach, okay? And it's good for visualizing neoplasms, polyps, and diverticula. Okay, I forget the difference between singular and plural.
The UN plural.
Plural is diverticulum. Okay, so it's good for looking for those pouches, inside and outside pouches, for a double contrast study. All right. So here, what is this area right here?
Cecum,
Cecum. What is this little tail?
appendix,
Appendix.
ascending, transverse, descending, sigmoid.
Okay. So what you see in the anatomy books is pretty plain and simple. You know what goes up, across, down, and S's. But in reality, the shape and the way the bowels hang is dependent on body habitus. Okay? So you will notice that from person to person, the lips of bowels may change in its orientation in the abdomen from the different types of patients. Okay, and then we have which flexure here?
The hepatic,
Right, and then your
Splenic.
Left or splenic, okay. All right. So the difference between large intestine and the small intestine. So there are three main differences. The first one is the internal diameter. The large intestine is greater in diameter than the small intestine. The second characteristic of the large bowel is that it has 3 longitudinal bands of muscle. This is known as the tinea coli. Tinea coli. Okay, so 3 bands of horizontal muscles. And it is attached to the outside of the intestine, and it acts like a cinch in a purse. So it has the ability to cause the colon to expand and also contract. So the tinea coli also forms these little pouches in the large bowel, and this is known as haustra, and plural is haustrum.
Wait, the haustra are the pouches? And
The haustra is the pouches, and the tinea coli is the band of muscle. Was that your question?
Yep.
Okay. All right, and then lastly, third characteristic is the location of the large intestine. And where is that?
On the periphery.
On the periphery, right? And centrally is the
Small intestine.
small intestine. All right, any questions so far? Okay. Just like the stomach, you have to be familiar with the location of barium based on the position of the patient. So if we're doing a double contrast study, and again, this only applies to a double contrast study. Okay, it only applies to a double contrast study. When you are supine, okay, first of all, before I go through this is the orientation of the colon. Ascending, okay, ascending is anterior. Transverse is posterior. Descending is anterior. And then the distal descending, because parts of the descending, the most proximal is anterior, and it starts to make its way posteriorly in the descending portion. In the descending portion. So it's more anterior up here and more posterior down here. Okay? And by the time it reaches the rectal sigmoid area, it's back again. Okay? So it goes front, back, front, back. It alternates. Front, back, front, back. Okay? So with that said, when a patient is supine, double contrast study. Oh, what did I just say?
No, it's the
Sorry,
opposite.
the opposite.
Yeah. It's all right. You got
Okay,
love on your mind.
Back.
What?
Yeah. Back,
okay.
front,
Sorry.
back, front, back.
Can you rewind that? Okay.
YouTubers, that was incorrect. He's gonna correct it right now.
It's back, front, back, and then front.
Oh, it can be front.
But it still alternates. Yeah.
Yeah.
Yeah. Back, front, back, front. Yes.
Correct.
Your anus is on the back.
That's what they say.
So is yours.
That's what they say.
That's okay.
I hope it's not in the front, dude.
You didn't mean that.
It's
That was a good one, Bahar.
opening, I mean, it's in our rear end, okay, but it's still anterior when compared to the other parts of the colon. There's the anus, there's the rectum. So the rectum is on the back, and then it starts to come up here a little bit. So yes, it's in the back, but it's more anterior in relation to the other colon. Okay? All right. So when the patient is in the supine, position, okay, so the ascending and descending are posterior, so that's where the barium is going to settle. Okay, then transverse and distal descending in the rectal sigmoid area will be filled with air. And then when you flip them on your belly, okay, now the air is going to go to the ascending and descending while the barium sits in the transverse, and then the distal part of the descending colon, and also parts of the rectal sigmoid area. Now, that's kind of the baseline, but again, depending on the body habits of the patient, it may change slightly. There may be some slight variations of where you're going to find that air in the barium, but this is the general rule of where you will find those two contrasts, air versus barium. All right, so here we have this is a double contrast study. This is in AP, and how do we know that's in AP?
Because the barium's in the ascending and descending.
Okay, so again, the majority of the barium is going to be in the ascending and descending, and air rises towards the anterior portion. So here we are right here, and then you have partial filling here in the rectal sigmoid area as well. Okay. All right. A. What part is that?
Cecum.
Cecum.
Ascending.
Ascending. Okay, and remember, like I said in the pictures, it shows the transverse colon very nice and linear, but it does take a dip. So this is transverse.
Hepatic flexure.
Okay, hepatic and spleen. Hey guys, why is this lower than the one on the left?
Because of liver.
Because of his liver. Okay, and what's this?
Descending.
Descending, and then you have your
Sigmoid.
Okay. The area over here where, what is this?
The terminal ileum.
Okay, this is the terminal ileum, so this is the ileum, okay? And then,
Ileocecal valve.
what kind of valve? Ileocecal valve, and then this is the,
Cecum.
okay, this is the cecum, okay? And what's this?
Ascending.
Okay, so this is the cecum, this is the ascending, and then down here, you can't see it, but you should see the appendage down here somewhere. All right. All right, so here we have a lateral rectum. G is pointing to the sigmoid colon, and H is the rectum. So the rectum, let me see, what position is this? What position is this? It says it's left lateral. Oh, I guess it's lateral. Okay, so it's lateral. But now we have, so what is this black area right there? Someone said poop. Isn't poop solid?
Air.
Okay, it's
The
air.
gas is
Air
coming
from
out.
what?
The double contrast.
Okay. What we're seeing there is air from this. We're seeing this. That's the.
It's like a donut.
This is air in the balloon tip enema. Have you guys seen this before? There's a lot of air gasping.
It's not used, is it?
No. So we'll go for the enema tip here in just a little bit. Okay.
Is that refurbished?
So that's air. So that's the air in the balloon tip, and you can actually see just a faint hint of the enema. You guys see that?
Mhm.
A faint hint, faint outline of the enema.
Is it because of they try to adjust the angulation? That's the reason they put the balloon to make it easier for the angulation?
No, the whole purpose of the balloon so you don't
Keep it in there?
out.
Yeah. What was it again? Wait, the video didn't get that. Say it again.
Yeah, leaky faucet.
Isn't that a right?
Oh, severe leakage?
Anal leakage.
I don't know.
Because the
What's your conclusion? How did you determine that?
because H is supposed to be anterior, right? Then G. G is supposed to be posterior than to relative to H.
Right.
So the only way that could
But why are the legs
happen
bent
is
like
if it's
that?
on the right side.
Mm,
No?
Demonstrate.
I don't know.
Sounds
No, they just-
It sounds logical.
I mean, yeah, I get it. But I mean, I think you would get the same image if it was a left lateral too.
But then H would be that way.
Huh?
If it's
Oh, I
left
mean,
lateral.
well, whether you're doing right, okay,
Why don't you
okay,
just
good
bend
point.
and
Whether
turn to the side and we'll figure it out?
Whether you're doing left or right lateral, whenever you're hanging up or visualizing a lateral image on the viewer, it's just like a chest x-ray. When you're doing a chest x-ray, it's hung so that they're facing your left. Okay? So whether this is a left or right lateral, you still have to put it on the viewer as if the patient was facing this way. That's why I was saying it could have been the other lateral.
And they
too.
just flipped it, or
Yeah.
what?
So I understand what you're saying now. So because it's pointing that way, it doesn't necessarily mean it's right or left lateral. That's just the proper protocol of hanging up or visualizing your image is towards your left. All right. Now here we have a single contrast or double contrast.
Single contrast.
Single contrast. All right. This is an LAO, left anterior oblique, which is very similar to that. What is the mirror image?
RPO?
RPO. And when you're looking at this image, everything looks very convoluted and pushed together. So you have the ascending, and the transverse almost as one piece. And that's because when you roll the patient up on either oblique, body parts will fall towards the gravitational side. So although this is LAO, it's very similar to that of what? RPO. So when you place the patient in an RPO, okay, everything starts to fall on the right side, and then the left flexure is going to be open. Does that make sense? So this is the ascending. Then you've got the flexure and the transverse kind of mixed in together because, again, of the obliquity. Left hepatic flexure is open. Descending, right? And then you have your rectal sigmoid area.
Mm. Okay, I see it.
Pardon me?
Opposite of
Yeah, so the LAO here gives you the same results as, an LAO gives you the same results as an RPO.
But you do the flexure. So the LAO use the right flexure better, and the
So the LAO visualizes the left flexure better.
left, wait, so it's the same.
The left.
So RPO.
Because you can
also
see
does
you can
that
see
for
the obvious
flexure?
flexure,
Yes.
right?
Yeah, so either the LAO or RPO is good in visualizing or opening up the left
Splenic flexure.
left splenic, the left colic or the splenic flexure. Does that make sense? Okay. All right. All right. So the summary of the lower digestive system functions. So this also covers what we talked about last week. So most digestion, absorption, and reabsorption occurs in the small bowel, especially in the duodenum and the jejunum. Okay? So digestion, absorption, and reabsorption occurs mostly in the duodenum and the jejunum. Digestion occurs through the process of chemical and mechanical means. And then by the time it reaches the large colon, some reabsorption does occur. But its main purpose of the large intestine is to eliminate any waste products. Okay, so the main purpose of the large intestine is to eliminate waste products in the form of feces, which is water, food residues, digestive secretions, and also bacteria. Okay, so again, most of the digestion, absorption, and reabsorption occurs in the small intestine. You may have some, you are going to have some here in the large intestine, but again, main purpose is for elimination, defecation. Okay. In what the large bowel is also going to do is that it synthesizes certain types of vitamins and also amino acids. And in the process of it producing these substances and also breaking it down, this is where flatulence comes into play.
Mm-hmm.
Okay, so this is where air starts to build up. Okay, so this is a natural occurrence in this process of synthesis. Remember, we're covering that in radiobiology. Okay, so this is where synthesis is occurring. So it's building up, producing certain types of vitamins and also amino acids. And then during the breakdown of that, gas is released, and also the gas helps in the breaking down of those different substances. You guys have this slide?
Mm-hmm.
Okay. All right, so movements of the digestive tract. We have in the large intestines, same thing as that with the small bowel. You have peristaltic and peristaltic activity. So those are your contractions. But what's also different than that of the small bowel is the haustral churning. Remember the haustras, the pouches? So literally what it's doing is each of those haustras are contracting, shooting the products into the next haustra, and then it continues to propulse it through the rest of the large intestine. Okay. Until you reach the very end, the end. Okay. And that's where you have defecation. Contraindications, very similar to that of an upper GI and a small bowel. What are they? Don't even look up here. What are they?
Perforation.
Okay, perforation.
Any type of surgeries, post
Okay,
or
pre and post surgery, and then most importantly, bowel obstruction. The contrast that we use, the main contrast that we use is barium. If you're using barium, okay, it has nowhere to go. It can solidify in your intestine and can cause lots and lots of problems. Okay. Lastly, here also as a contraindication is appendicitis. Okay. You don't want contrast going into that appendix, especially if you have appendicitis, because now you can cause a lot of problems. Remember, if you perforate that, okay, you can bleed to death from your appendix. Well, now let's say you have appendicitis and you have contrast, barium sitting in there, pressing up against the wall, you can cause necrosis in that area of the cecum. Okay, so not a good thing. Barium enema pathological indications includes colitis, ulcerative colitis, diverticulosis or diverticulitis. What's the difference between diverticulitis? What's diverticulitis, by the way?
Outpouching.
Okay, well, that's diverticula or diverticulum. So litis is what?
Inflammation.
Inflammation of, okay? So when we are talking about a diverticula, we're talking about the individual pouches, okay? We're talking about the pouches themselves, okay? Diverticulosis is the condition of having all those diverticula or diverticulums. Okay, so it's a condition of having a bunch of those. Diverticulosis. Neoplasms, abnormal growth. Volvulus, twisting, intussusception, telescoping, and then polyps, which is the opposite of that. So this is
Outpouch.
outpouching, this is
Inpouching.
inpouching. So here we have some pictures of ulcerative colitis. It's an inflammatory bowel disease that causes long-lasting inflammation and ulcers in your digestive tract. I put up there, that's not on your slide, that open sores, bless you, these open sores may destroy the mucosal lining, causing necrosis of the section of that bowel. It cause necrosis. Now, if the patient has a history of ulcerative colitis, is that also a contraindication? Yes. So if we are contraindicated for barium, what contrast should we be using?
Iodine.
Iodine. Why iodine? Because
Passive.
it is absorbable. Yes, it is absorbable. Okay. Diverticulosis of the sigmoid colon. So the difference between a diverticulum and a polyp is one is out, the other is in. Okay? So, guys, we are more prone to have diverticula. Supposedly it has to do with our diet, because we don't eat a lot of fiber. So it's linked to that. So something to look forward to, guys.
Yes.
Look at that.
Damn.
Is this painful?
Looks like
This is
it.
painful. Yeah, this hurts. It hurts. Double contrast or single contrast study?
Double.
Double contrast. Remember, double contrast studies is good for looking at polyps and diverticula. I can't get that. Is it diverticula?
No.
Singular?
No.
Lump.
Diverticulum is
Okay.
plural.
Pouches. It's good for that, and also neoplasms. Okay, there's more polyps. What's this?
Appendix.
So that's appendix, and what's this?
Cecum.
Cecum.
How you see it's inward or outward, diverticulum or polyps? I mean, how you can see it? Which
A
one
better view for this would be one of the decubitus films, and I'll explain that later on. When I say decubitus, you guys remember what decubitus is?
Recumbent. Crossbeam.
Okay, laying. Okay, it means recumbent with a horizontal beam. Okay, so I just said decubitus. So more specifically, is where you do a right lateral decubitus or left lateral decubitus. Is where we're going to see the polyps in the diverticulum. Okay. All right. So if this is a cecum, what's going on here? What's going on here?
A lot of distension.
Okay. Can you tell what position this is? Because, okay, so this, what is this?
Ascending.
This is ascending. Is this also ascending right here?
That's transverse.
This is part of the transverse, and you see that the flexure is closed up. So with this flexure closed up, that means this one is open. It is open, right? This is closed. So what position is this?
LAO and RPO?
It's either an
LAO.
LAO or
RPO.
RPO. Okay, one or the other. Okay, napkin ring or apple core, these are neoplasms. Yeah, not good. Cecal volvulus, so there's a twisting somewhere around here. And because there is a twisting, remember your large bowel fills up a lot of air. So air is trapped, it's got nowhere to go. So now you have dilated ascending and transverse colons. Okay. Can you guys see that a little bit?
See a lot of black.
Okay. Well, that's
Yeah,
air.
that's the air.
Yeah, that's air. Okay, another volvulus. Intussusception is a telescoping. Remember what I said last week? It usually involves the small bowel with the large bowel because there's a huge difference in diameter, and it's usually the small intestine slipping into the cecum. All right, barium enema prep. You think it's any similar to that of an upper GI or small bowel? Yes, okay. So same thing applies here, in that the patient has to be in NPO for a minimum of 8 hours. Okay, however, they are allowed to have a light evening meal prior to the exam. Okay, they are required to have a bowel cleansing cathartic. Cathartic is just basically a laxative. Okay, so that's what a cathartic is a laxative. Okay, possible no gum chewing or no smoking, because again, those two things will increase the
Saliva, gastric
I don't wanna say
juices.
it's not saliva, it's
Gastric
gastric
juice.
juices. Gastric juices. So the barium is going to have a harder time clinging into the mucosal walls. And then you also may require a cleansing enema in the morning prior for the patient coming to the department for their procedure. Up there, it is important to eliminate as much fecal material. Is this on your slides?
Mm-hmm.
Okay. It is important to eliminate as much fecal material from the colon and rectum as possible prior to the examination in a clear liquid